It is my pleasure to welcome you to our Demystifying Menopause series. We are excited to create a safe space for learning, sharing, and gaining valuable insights on this topic that impacts so many of us, yet is so often misunderstood. This series is thoughtfully organized by our dedicated health committee, led by the exceptional Sister Tenny Eppinger, our health committee chair. Thank you for joining us today, and we hope that this series provides valuable information, fosters meaningful discussions, and empowers each of us to prioritize our health and well being. Sister Tenny?
Thank you, Sister Tarina. Good evening, everyone. Thank you so much for joining us. I just wanted to share a little bit about the reason why we have created this three-part wellness series. The idea was to um, just sort of open up on this topic that is so important to so many of us, but to offer the accessibility to not just our chapter, but to Black women publicly. I do believe that sisterhood can change the world. And we really wanted to be our sister's keeper by talking about something that impacts so many of us during this stage of life. So thank you so much for taking time out to join us this evening. And we hope that you'll join us for the next 2 weeks as this series continues in its three parts. Thank you so much. Sister Katina.
Good evening, everyone. I want to thank you all for being here, and I want to take a moment to introduce our speaker, Dr. Janet Williams. Dr. Janet Williams is a licensed physician and surgeon based in Los Angeles, California. She is board certified. She's a board certified in obstetrics and gynecology, and an expert in sexual medicine and an advocate for women's health. She's been helping women find solutions to their reproductive and sexual health for over 25 years. Dr. Janet is an intimate life coach and hypnotherapist at goodgroove.com. She has a virtual coaching and hypnosis programs, especially for women. She is the author of the Amazon best-selling book, Why Don't I Like Sex Anymore? The Grown Woman's Guide to Getting Your Groove Back and Claiming Your Truth. Like many Black women, she has had her share of challenges balancing career, relationships, and health. In her early 40s, she faced a difficult fertility journey that rocked her confidence and intimate life. Through therapy, life coaching, hypnosis, and her medical expertise, she was able to find and heal and rediscover her pleasure. That journey took her from a devastating IVF failure and zero libido to meeting a new partner and experience the best sex of her life. Dr. Janet brings those personal and professional insights to her work. In addition to being an active OBGYN, she is a coach that helps midlife women master their perimenopause and menopause journeys, reclaim their pleasure, and make their sexual comeback. Through her coaching and hypnosis program, courses like Confident Pleasure courses, and digital tools like the Hot Flash Chill system that supports women, many of them Black professionals and over 40, in navigating the life changes that can impact their confidence and well being. Dr. Williams believes every woman, regardless of age, race, shape, or belief system, should have the power over their own body and the right to express herself sexually and the ability to dictate her own brand of pleasure. Introducing Dr. Janet Williams.
Hello, hello. How is everyone? Thank you so much, Katina. Thank you for having me here. It is a pleasure to be with you all. I look forward to getting into the series and talking about something that is so very important. The single most important thing I want you all to take away with yourselves today is that this webinar series is in this webinar series is that menopause can be fantastic. Okay, it can be fantastic, but only if we understand it and only if that's what we're set out to do. And that's what we're here to do, is to understand menopause. So let me get into sharing my screen here. Let's see here. I want to use this one here. Share. And I'm going to do 1 second slideshow. This interview. Okay, can you guys see me? Okay.
Yes,
Okay. And are you seeing just the slide, or are you also seeing my stuff too? Hello?
we can see I
See
can see the slides
everything.
and
Oh, we don't want that. Okay, let me stop the share for one moment, you guys. Let's see if I can switch this out. And show. Sorry, guys. Let's see. Show. Okay. All right. Well, I will start. Oh, no, I didn't share us. Okay, here we go. Try that one more time. 3 times is a charm, right? Okay. Okay. There we go. All right. So I want to start this off with an embarrassing story that I have. So this happened to me about, I want to say 3 years ago or so. And I had a date, you guys. I was looking cute. I had a little off the shoulder situation going on. My look was, my hair was popping. I had the blowout, bouncing and behaving. And I got to this date, where it's sushi. We're outdoors. It's sort of like a little sunny day. I'm cute. Outdoors, we've got sushi, there's edamame, there's sake, and the vibe is vibing, the flow is flowing. And out of nowhere, y'all, I get hit with the hottest of hot flashes. And I'm talking about, I just stepped out of the sauna. I might have run like a 5K kind of sweat situation. I'm drenched in sweat. This is not the cute little, oh, I'm gonna tap myself dry. It was a mess, really. And so I say all that to say that, even though I am a gynecologist, I'm a hormone expert, I am someone who believes in the mind body connection and all of those things that, can take place. I was here hit over the head with bricks like of sweat in this severe hot flash. And it was like a master class in menopause and perimenopause that I did not sign up for. But yet there I was. And so I am happy to say that I have, used therapy and a number of things that we'll discuss today and then throughout the course of this series to, resolve those. And so I was able to get through that. I also want to say, as a gynecologist and a hypnotherapist, I do believe in both, modern medicine and hormones. So sort of a disclaimer. And I also believe in the mind body connection, things like hypnosis and other natural approaches to menopause care. So I, approach things from a kind of fuller picture. Okay. Let's see here. So why is it important that we talk about menopause at every age and not just when we go through menopause? It's important for family planning. So there are women that I've seen that have come into my clinic as patients, and they're in their 40s and they're having, expecting to be able to get pregnant, and they might be beyond their fertility window. And so we're not having these conversations. There are some people that are not aware of the timeline of what happens and when you can continue to have babies, when you can continue to get pregnant, et cetera, et cetera. So that's number one. Number two is expectations and intervention. So knowing, had I not known what that was, a hot flash, that could be overwhelming, right? You're at a date and you're out of nowhere, this is coming up and you're not expecting it. So not having that knowledge is going to get in the way and maybe alarming. It might be a cause for fear. And so having that expectation, knowing when the timeline is for these changes to be happening in our bodies is going to be very important for us. And then being able to have the knowledge that there are interventions, because not knowing that there are interventions can be scary. And then it can really derail you and think and have you thinking that you're headed down a negative road and it's the end for you, when there are really lots of different options, different things available, different things that you can do. So, and then third thing, and this is my favorite one, is that we are able to design our lives. Like we can plan and we can design our lives the way that we want them to go. I want everybody to drop in the chat right now, I can design my life. Drop that in the chat for me. Okay. See any of those coming through? All right, design my life. And I want you to begin thinking about what would that look like? You know, when we have these problems that that are presented in our lives, like I want you to know that there is a solution to every single problem, right? And so when we're faced with these problems, I want you to begin thinking like, what would my life look like if this problem had a solution? What would I do next? Like, where would I go? Let's expand our minds and think beyond like, the problem menopause. Okay, what happens once we've solved these problems? That means we can design our lives. Okay. So, why haven't you talked to your doctor about this, or why do you think that is? And I'll tell you, it's for a couple of reasons, many reasons actually, but one of the biggest reasons why we see that happening is that there is a lack of research. There's a lack of research, and it wasn't until 1993 when women were actually included in research in a lot of the double-blinded, randomized controlled trials. So we weren't seeing our involvement in a lot of the studies. They used to just take whatever they researched in men and just extrapolate it for women, which doesn't make any sense. So that's one reason. And then the other reason is just a lack of medical training. When I was in medical school and residency as an OBGYN doctor, I got very little education on hormones and what they do in our bodies and what needs to happen. And so there is a huge gap in the medical training. I remember as I started as an attending physician, so you go through medical school, you go through your residency, and then you start as an attending in practice. And I kept seeing lots of 45, 50-year-old women coming in with issues with their libido and issues with hot flashes, and there was just I had no education, I had no training. And when I asked like my colleagues, my more senior colleagues, there was a lot, they didn't have much either. And so this is a field that is getting a lot of attention right now, which I'm so happy about. But that medical training has not been there. And so that's why you may not have heard about this from your doctor. So what is menopause? Let's pull the veil back, okay? Basically what it is a permanent end of menstrual periods. And that's it. It's like when you have your last menstrual period and now then you've gone through menopause. And so it is sort of a journey we have. It is a transition. So menopause, you've got perimenopause, you've got menopause itself, and then you've got postmenopause. And this is a transitional thing where we go from being fertile and having menstrual cycles and having ovulation to having none of those things. Okay. And then there's a whole host of like things that come up, symptoms that happen, things that you'll feel during this time. So one of the questions, some of you all filled out a questionnaire when you registered for this webinar. And one of the questions that was on that was, what are the signs and symptoms of menopause beyond hot flashes? And that's where we get into perimenopause. And perimenopause is the time period that happens before menopause. So it's generally a couple of years before menopause, and then 1 or 2 years after is considered perimenopause. So it's the time around menopause. But when most people talk about perimenopause, they're talking about the time prior to menopause. So, and the things that we can look out for are going to fall into that category. So, what is it? So I always compare perimenopause to a roller coaster. So it is, you're all over the place. The hormones are up, the hormones are down, they're turning around. You're feeling good, and then you're feeling horrible, and then you're feeling hot, and you're feeling cold. It's a hormonal mishmash, willy-nilly. It's a mess. Okay, so there are several stages. So if you have early perimenopause, and then you have a later perimenopause. In this slide, we're talking about early prior to age 45 is considered early, and then premature is considered anytime before age 40. But 40 to 50 is kind of the range where we see people starting to see some of these symptoms that come up in perimenopause. So this is another question that someone had put into the questionnaire, and it said, can you explain anovulation? I am reaching perimenopause. I still have a monthly cycle, but I do not appear to be ovulating. Is this a part of menopause? And so the short answer to that is yes. And what anovulation is, first I'll explain that anovulation is basically saying that you're not ovulating. And so when you are anovulatory, so I'm going to show you this slide here. This is what happens every month in the monthly menstrual calendar, every month menstrual cycle, right? And so you have these hormones that talk to each other and tell the body what needs to happen. So in the first part of the cycle, we see in the first part of the cycle, we see the hormone interplay here. So you have the FSH, LH, estrogen, progesterone. These are all hormones that direct the body to release an egg. They direct the body to prepare the lining of the uterus for implantation if pregnancy occurs. And there is a nice harmony that happens. So they bump up, they bump down, and they do this dance. And around about halfway through, so in the first half of the menstrual cycle is where you see the body preparing and getting the lining of the uterus. At the very beginning is where the period occurs, and then this process begins. In the middle of the cycle, about 2 weeks in, you will have ovulation, and the egg is released from the ovary at ovulation, and that is what ovulation is. The egg is being released. At the second half of the menstrual cycle is where we see some hormonal changes that are getting ready and all the way prepped for if implantation occurs. If implantation does not occur, then you shed off the lining of the uterus and have another menstrual cycle. And so this is the normal cycle. We have that ovulation, we have this hormonal balance that happens here. The progesterone goes up, the estrogen also goes up, but not as much as the progesterone. And this is what happens in the normal cycle. What happens in perimenopause is more roller coaster activity. So you see in this image here, we've got these hormones that are going up and they're going down. And instead of the estrogen, going down like it's supposed to do, it's going up. It's doing all kind of willy-nilly stuff. You might have multiple ovulations. So you might have ovulations that are back to back, and then you have like a long period, or you might go several months and not have an ovulation. So in perimenopause is where we see all of this stuff happening, and a lot of changes that are going on that are erratic. So we end up seeing a lot of irregular periods. We end up seeing heavy periods. Because of the decrease in estrogen, we see hot flashes. So one of the things that estrogen does is it helps to regulate the temperature regulation areas in our brain. So the estrogen helps to, it's almost like a thermostat for the brain, okay, to tell you it's 70 degrees in here. The estrogen is there. It says, yes, it's 70 degrees in here. We don't need to sweat. When those estrogen levels are low, the body tells us, you know what, there's been a change in temperature. It's hot in here, girl. You need to cool yourself off, right? And so it tells the body it's hot. We need to cool it, activate all of the things. We're going to start sweating. Your respiration's going to go up to cool off. And that's the reason for those hot flashes that we see. Another thing that a lot of women who suffer from fibroids will notice is that fibroid problems will increase. And so there is the extra estrogen that can occur in that second half of the menstrual cycle in perimenopause, and that can lead to growth of the fibroids, pressure, which can cause extra bleeding and lots of heavy bleeding, sometimes frightening bleeding. So if you're having any of that, please see your doctor. But this is why a lot of times we're seeing this happen in this time period. And that goes along with the heavy periods. Emotional problems. So if you are someone who has experienced premenstrual syndrome or premenstrual symptoms, where you feel tired, you feel moody, you feel short. Maybe your partner is usually somebody you're like excited to see. And when that time of the month rolls around, you're like, if you don't get out of my face, you want the kids to go sit down somewhere. All of these things are emotional issues that can come up normally and very commonly in perimenopause related to those hormonal changes. And so if we take a step back and look at the grand scheme of things, we have here, let's see, here. At the very beginning, at puberty, at birth, we have about 7 million eggs. I'm sorry, at 5 months, we have at 5 months gestation, when you are a fetus inside of your mother's womb, at about 5 months along, you have about 7 million eggs in the eggs of the fetus. At birth, that number drops down to 1 to 2 million. And at puberty, we're all the way down to 300,000 to 500,000. And, some of those eggs are lost in ovulation. Some of those eggs become our children. Some of those eggs dissolve and just die off. And that's actually most of the eggs dissolve and die off. And as we get closer to perimenopause, we're down to like 400 eggs. By the time you reach menopause, it's like around 300 eggs or so. And most of those eggs at the perimenopause and menopause time frame are not active eggs. So you might slip one out and get a surprise baby at the end of your reproductive years, but for the most part, those eggs are not active. And that's why it's so important for family planning that we're aware of this, that, after, 40 to 50 is the time frame of perimenopause. And even though you can get pregnant, most people, the eggs that they have remaining are not active eggs. So something to think about. The other thing I want to make note of here is that menopause is an event. So it is the day that you have gone 1 year without a menstrual cycle. And that's it. Menopause is 1 day. And then after that, you're postmenopausal. And so we don't know actually if we're in menopause until a year after we're in menopause. Because if you're having all of these fluctuations in your hormones, maybe you're one of the women who goes months without a period, you don't know if that's your last period or not, because you might go 6 months and then have another period. So it's a little confusing. People are always like, why, am I in menopause? I don't know. I'm not sure. And there's some controversy about like whether or not to get testing. People are always asking, can you test me to see? Now, we can do testing, but it's often not that helpful to get hormone testing because of those fluctuations that happen. So if you've got fluctuations going up and down and up and down, we can see if it's up, but maybe next month it'll be down. And so that's why we use the menopause and the last menstrual period as our reference. And we really kind of manage the symptoms based on what you're experiencing as opposed to what the hormone levels are. Okay, so like I said, menopause, it's your last menstrual period. You can get rid of those tampons, you can throw out those pads, hooray. And it is it's the final frontier in those pads. And early menopause is between age 40 and 45. The average age for people to go through menopause is 51. And then late menopause tends to be at age 55 and above. Okay, so what's actually happening inside? So the ovaries stop making hormones, and the primary hormones that we talk about are estrogen, progesterone, and testosterone. Okay, and so estrogen is a huge hormone in our bodies. It is literally involved with pretty much every system in our body. So from the temperature regulation in the brain, from our skin, bone health. Bone health includes your teeth health. You've got changes in the cornea that can happen. So you can have changes in your vision, dry eyes. You can see all kinds of things in different systems in the body. It's very integral in the changes that we have in our body. The primary location for the production of estrogen is from the ovaries. In menopause, those ovaries shut down. There are some estrogens and testosterone and other hormones produced in the adrenal glands. The adrenal glands are glands that sit on top of the kidneys. So there is some production in the adrenal glands, but it's very limited. So we can see like extreme changes in all of our systems pretty suddenly. So people will be doing fine in the perimenopausal period, and then they, that sharp drop off of the estrogen from the ovaries, and people start seeing changes and all kinds of like not so friendly changes. So like I said, postmenopause is the stage of life after your final menstruation. So once you went through that event, then the rest of the life is postmenopausal. And like I mentioned before, the estrogen drops down and that cycling stops. One of the things that I really want to bring attention to is the changes that can happen in the vaginal tissue. On the left-hand side here is a close-up view of the cells in the vaginal wall. And then cells in the vaginal wall have what we call rugae. It's like folds, almost like an accordion. So there's folds, and it's fluffy, and it's soft, and it's moist, and it gets nicely lubricated for intercourse or sexual activity. And then one of the things that can happen when we go through that menopausal transition is that estrogen levels drop down. The receptors in the vaginal tissue are not getting stimulated by the estrogen, and we see that nice fluffy rugae flatten out. And what that does is it decreases the lubrication. It makes the tissue very thin, and it can make things very dry, and it can make things extremely painful. So for a lot of women, what we'll see is suddenly they have, severe pain or discomfort, dryness, even tears that can occur in the vaginal tissue with intercourse. And I want to bring this to our attention because there's a very simple fix for this, and that is vaginal estrogen. You can use vaginal estrogen. You can use lubricants, different types of lubricants. There's vaginal moisturizers called hyaluronic acid moisturizers. But really, almost anyone can use vaginal estrogen for the vaginal tissue. People worry about estrogen, but really the concern for estrogen comes when we're talking about systemic estrogen, something that's absorbed throughout the entire body. And there's some, cardiovascular risk and cancer risk that may go along with that, depending on your situation. But by and large, most people can use vaginal estrogen safely, and that can have a huge impact on your well-being and your quality of life. So if that's something that you're struggling with, just have that conversation with your doctor about it. If your doctor is unaware, because some of us doctors are still not aware that this is an option, and it is very, very low risk. I just wanted to put that out there. Tell your girlfriends, tell your friends, your grandma. Everybody needs to know that that may be an option for them, and we don't need to suffer with that issue. Okay, so what else is going on? All right, so we talked about hot flashes. We talked about, how the thermostat in the brain miscommunicates once that estrogen is low. And one of the things that we can see with hot flashes is hot flashes that occur at nighttime. Those are called night sweats. And sometimes people don't even realize they're having hot flashes, but you may wake up at 3 o'clock in the morning, 4 o'clock in the morning, and can't get back to sleep. Is there anyone here? I want you to drop in the chat if you have sleep problems. Just drop in there sleep. I want to get a sense of if that is something that people are dealing with. I know for me, there was a time I would be popping up at 3, 4 o'clock like clockwork and having just these horrible hot flashes that I could not get back to sleep, just waking up sweaty. Yeah, I see some sleep in here. Yep. Okay. Yeah. So it's a thing, y'all. Okay. And so sometimes just getting those hot flashes treated can be very helpful in resolving those sleep issues. And I want to bring this one, up because sleep is so important for our health and well-being in all areas, right? If we're not getting enough sleep, that the cortisol levels in our body are high, our inflammation is high. The sleep is our time for our bodies to heal and our bodies to do their work. They get in there and they're like, all right, we're going to fix this, and we're going to fix this over here, and we're going to fix this over there. But if we're waking up and having disturbed sleep, interrupted sleep, and we're not getting that good quality, I call it sexy sleep. I want that sexy, good sleep. Then we run into all kinds of downstream problems in the daytime, right? So that can interfere with your work. That interferes with the bag, like it's getting in the way of our money and our in our family. Like it just goes on and on. So we want to get that good quality sleep, that good sexy sleep in. Yes, Katina, you want sexy sleep. We all should have it, and we're going to get to that, right? So let me close that up. The other thing is that we talked about the vaginal dryness, and so that is a thing. Brain fog, that's another one where the mind is just doing its own thing, right? Like you go into a room and you're like, what did I come in here for? I know there's something. Can't remember words, can't remember what you're saying, and your brain is on fog. So that happens, and that is a part of it. It is real. It is so real. Okay. And mood problems, I kind of mentioned that as well. Joint pains, we can get little aches and pains, and you're like, why? It's like I hear people say that all the time. You turn 40 and suddenly to stand up out of a chair, it's like, what? It's not a game, like it's a real thing. Bone loss. That one is a very important one because, bone fracture as we age can be dangerous. It can be a problem for our health. And the reason why we see bone loss and osteoporosis after menopause is because estrogen is an important factor in the way that the bone remodels. So the bone is always remodeling. So it's like building up, it's kind of taking some old stuff off, building up and taking some old stuff off. And the estrogen is important in kind of preventing the breakdown from happening. And so when we have that regulation that changes estrogen is down, the breakdown happens more than the buildup happens. And that's where we run into problems. And so that's part of the reason why we want to, strengthen our muscles, and the muscles kind of support the bones get that protein in. Those are some of the reasons why we want to, boost up the bone health. Dry eyes, dry mouth. These are things breaking off nails, your nails just cracking off for no good reason. Like that's a thing. Hair loss, hair thinning. Yeah, so estrogen is also important in the normal cycle of our hair. So there is growth cycles and then we have shedding cycles. You might have experienced this in pregnancy. A lot of people, when they're pregnant, they have hair is growing, the estrogen is flowing, their hair is beautiful, and then they start breastfeeding, and a couple of months down after the baby, then the hair is falling out. It's the same principle. It's that estrogen, those estrogen levels that are low. Ringing in the ears, itchy skin, bladder weakness, some of the muscle, some of the ligaments and structures that the collagen in our skin is heavily impacted by estrogen. And so as that estrogen dips down, the collagen gets a little lower, those connective tissues get a little weaker, the bladder loosens, and we're peeing on ourselves now. All right. So this is a thing that happens, and we, it's good to be aware of it. Body odor is another one. Here's an interesting thing that can happen where you have less estrogen. So the androgens in the body, like the testosterone is an androgen. So the kind of, it's male hormone, but it's really not. We both have male and we both have testosterone and estrogen. So, but the male quote unquote male hormone is higher, and so there's different bacteria that live in our bodies in relationship to the estrogen and testosterone levels that exist, and that can cause changes in the way we smell. So what are you feeling? Is there anything on here that I mentioned that you all are feeling? I know we talked about sleep. What other, drop in the chat any of the other things that you might be experiencing. Okay, let me jump in here into this chat. So I see brain fog, can't seem to cool off. Told 60% of divorces are initiated during this time. Oh, I'm not sure about that statistic, but I understand why. Like a prepubescent boy child. Okay. The bladder, yeah, definitely crazy. Why it makes you feel crazy. Symptoms come and go, all phases, brain fog, big time, weight gain. Oh yeah, I didn't even mention that. Weight gain right around the midsection. The place where your body deposits the fat changes, and so you might have been snatched, right? Like I was snatched, and I'm eating the same things, I'm doing the same workout, and now all of a sudden, I look like Santa Claus. And so that thing is a real thing. It's related to how the body begins depositing its fat. And there's some things that we can do, thankfully. Brittle nails. Yeah, didn't realize that could be a thing. Low sex drive. Yep. All day. That can happen. I've been there. And thankfully there are solutions to all of these things. So I love that. Okay, so let's see here. And so that, you all, is the menopause, perimenopause transition journey. So my question to you is, how will you feel? This is Ernestine Shepherd. I've been like low-key stalking this lady for the last like maybe 10 years. She is an 88-year-old bodybuilder. I'm like, come on, Miss Shepherd. That's what I'm talking about. That is what I'm trying to feel like Miss Shepherd looks. Okay. I think she's 88, Simone. Yeah, so that's what I'm trying to, yeah, right? I mean, look at those abs. Come on, Miss Shepherd. It's possible. And that's how I'm trying to feel. How are you all trying to feel? I want you to drop a word that describes how you are trying to feel. Healthy, yes. Optimal, ooh, yes. Happy, motivated, okay. Like my old self, okay. Energetic. Katina, what does your old self feel like? Like what? Like how does that feel? Charged up, complete, yes. Amazing, yes. Empress. Let's feel amazing, charged up, energetic, invigorated. Yes. What else do we have? Energetic. Yep. There we go. Good, good, good. All right. Love it. Yeah. And all of these things are things that we can achieve. We can feel energetic. We can feel invigorated and amazing. And then I also want you to begin thinking radiant. That's a great one. I also want you to begin thinking about what would make you feel energetic. Like, let's say you had the energetic energy, you felt renewed, radiant. What would you then do with that energy? Are you spending time with your family? Are you traveling? Like, what is the dream? I want you to think about that, because it is a reality that we can design. Okay. Renewed. I love it. Okay, I am actually gonna stop my share. And so that's it for today's presentation. I do want to say, there are kind of three areas that we think about when we are thinking about designing these dream lives that we want, in menopause, feeling radiant, feeling energetic, feeling whole, and healthy. And there's generally three parts that we want to take a look at. One is, so there's biology, psychology, and social. And the first part, what we covered today, is sort of understanding kind of what's happening, right? What's going on in the body, that's the base of it. Like, we got to figure out, we have to understand what's happening, because what that does, it takes away the fear that comes along with it. Because you have all this, like, all the stuff that's going on in your body. Even sometimes the hot flashes come with palpitations, and it just feels like, anxiety attack. Like, what is going on? When you have an understanding of what's going on, it can sort of like calm things down, and you say, okay, well, we've got this issue, we've got this symptom, it's a problem. How are we going to fix it? And I just want to reinforce that every problem has a solution. And so it's a matter of, figuring out what your solution is. There's no one size fits all. When we talk next week in our group session, again, we will be going over some of the, not all of them, but like a good chunk of the solutions for some of these issues that we talked about today. And so we'll be able to dive in a little bit deeper into that. So getting into the biology and the solutions that surround those. Some of those are medications, some of those are hormonal, non-hormonal supplements, behavioral things that we can do. Some of the mind-body practices. I am, of course, biased as a hypnotherapist. There's so many amazing things that we can do with hypnotherapy and the menopausal transition, and readjusting the mind, and even with hot flashes, so many amazing things that we can do with that. And so that is the third part, and the second part. And then the third part is, once we've got the tools that we need, some of the solutions, some of the therapeutic options, once we get some of those, then we'll have the ability to design the next phase, design that postmenopausal experience into what we want it to be, and like expand that greatly. Okay, so let's jump into some of these questions. Are over-the-counter vaginal estrogens the same as or comparable to prescription options? I don't believe so. So I'm not even aware of any over-the-counter vaginal estrogens that would be maybe phytoestrogens. Are you talking about like oral estrogens, Dr. Monica? Amazon has a vaginal. Are they pills or? Yeah, I'm not aware of any vaginal estrogens that don't require an prescription. I know that there are some creams that are phytoestrogens, so that means they use plant estrogens. Most of those are not like FDA regulated, and they don't have studies behind them. So that may be what they're talking about. There are some, like there's a supplement called Estroven that has phytoestrogens in it. And that is helpful for hot flashes in maybe 40 to 60% of women. But as far as the vaginal cream, I'm not familiar. I found pills and creams just from a quick Google search. Can you recommend a good prescription vaginal estrogen? Yeah, so estradiol vaginal cream is a good vaginal estrogen to use. There is estradiol vaginal cream, and then there is also Premarin cream. Now, Premarin cream is a horse-derived estrogen, and those tend to be a little bit stronger um, and not bioidentical. So bioidentical means that it mimics what your body does. And so I generally will prescribe the estradiol vaginal cream and not the Premarin cream. Is the vaginal hyaluronic acid over the counter? Yes, that is over the counter. There are some of those. There's a number of those over the counter. What other questions do we have?
Dr. Williams, we had a question earlier about the
Mhm.
age for perimenopause.
Yeah, so the age of perimenopause starts at 40. From 40 to 50 is the general age of perimenopause, and early perimenopause is before age 45, and then 45 to 50 is, kind of standard. Are there cancer risks associated with pills and creams? Are you talking about the over-the-counter pills and creams, Lysandra? Sorry. I'm not sure about the risk of the over-the-counter. Oh, with prescription. So with prescription vaginal estrogen cream, the risk is very, very low. If you have a breast cancer that's estrogen sensitive, I would recommend talking. Generally, what we do is recommend you talk to your oncologist. And most oncologists, by and large, would still say, yes, it's fine, it's safe. The reason why is because the estrogen from those vaginal preparations, a vaginal estrogen cream, has very low absorption into the system, into your bloodstream. And so when we're talking about estrogen sensitive cancers, we don't want to give something in the bloodstream that's going to go to that cancer and then potentially like feed the cancer. But with the estrogen vaginal cream, there's very minimal absorption into the bloodstream. So the risk of, that type of estrogen stimulating estrogen sensitive cancer is very, very low. But that being said, if you have a breast cancer that is sensitive to estrogen or any hormones, I would, discuss it with your oncologist. That's what I normally do, when I have a patient who has that breast cancer history. We talk it over with the oncologist. Most of the time, the oncologist says it's perfectly fine, and then we, move forward with it. And that's why, there is no one size fits all. You do want to talk to your providers, your clinicians about, what treatment is right for you. But that generally is an option for most women. Will you still feel perimenopause symptoms if you have an IUD? You might feel some of them. Is it a Paragard IUD, the copper 10-year IUD, or the Mirena IUD? Mirena, yeah. So Mirena IUD has progesterone in it. So what progesterone does, if you guys remember the second half of that menstrual cycle, so the progesterone goes up and the lining of the uterus sheds off. When you have a Mirena IUD, that progesterone is there all the time. So it prevents that lining of the uterus from building up like it normally does. It's actually very helpful if you have extremely heavy periods because it kind of keeps the level of the lining from building up too much. So you may not have the symptoms like the menstrual symptoms of perimenopause if you have an IUD in place, which is great. Like we don't want those symptoms, but you may not have them with that IUD. On the other hand, you could still have other symptoms. So you could have hot flashes, you could have, some of the mood stuff, mind fogs, and all of that going on. So, okay. What
We
else?
had some earlier questions. I know you mentioned that you should treat by what your symptoms are versus your hormones? Should you have
Mhm.
your hormones checked anyway?
Here's what I normally do. I don't routinely check hormones. If someone comes in and they want to have their hormones checked, I'll check them. We do want to check things like your thyroid to make sure it's not, one of those things going on. And oftentimes, if I'm checking your thyroid, I might throw in another, test in there. Some of the tests that we can check are the follicle stimulating hormone, or FSH. Another test would be an estradiol blood test, and the thyroid test. But like I said, we don't necessarily need the estrogen test, because again, those hormones fluctuate so much. So if you came in to me and said, and I looked at your chart and you're 45 years old and you told me, like, I've missed a couple periods and I'm having some hot flashes at night. I mean, I kind of know you're in perimenopause. You've got like the things already happening. We can check a thyroid to make sure that there's not, any issues with your thyroid, that because sometimes those symptoms kind of mirror each other. And so we can use a thyroid test to make sure your thyroid is good. And if you wanted to, I'd be open to, checking the hormone levels, but it's not necessary. It's not necessary for the diagnosis.
Thank you. Is there any concern about if your hormones weren't low and you were getting um, taking estrogen, that the estrogen levels could become too high?
If you're Well, here's the thing again, and this is why we're not doing it based on hormone levels, right? So if you're in perimenopause, right? Um, we generally, and that means you're still having periods, we generally will use like a low dose birth control pill, or a low dose estrogen, which is going to be low dose. It's not going to be higher than your normal, like, physiologic estrogen levels. So the risk of your estrogen levels being high, like too high, is not really a thing, right? The amount that is in the estrogen, like, patch for hormone replacement therapy is so much lower than like a birth control pill. So the level of estrogen and progesterone that we're using is a lot lower than even the birth control pill. And it's a lot lower than what our natural levels are before we go through menopause. So even if you were to use menopausal hormone replacement therapy in a woman who's perimenopausal before she's actually in menopause, it's not a huge jump, because the levels of estrogen in your body are still so much higher than what you're getting in those prescriptions.
Great. We have a couple more questions from before. Do women test positive for pregnancy during perimenopause or during that first year? False positive, excuse me.
Not any more than otherwise. Is that something someone has experienced? No?
If someone wants to reply to that, if they had an experience with that.
Okay. Can you suggest some suggestions for combating? We're going to get into some of those options in the next session. So we'll hold on to that question. Yeah, that's a big one. It's like, really? This is what we're doing? Yes, I will, but I can touch on that a little bit. HRT with hormone replacement therapy with pellets. So here's the thing with the pellets. I'm not a fan of the pellets, because people love the pellets because it's sort of like a set it and forget it. You get the pellet in there and you don't have to think about it. And they put in, they often will put in testosterone, progesterone, estrogen, all of the things in there, and just like a big hodgepodge. But the pellets are not FDA approved. And you'll hear people talking about bioidentical hormones. And bioidentical hormones gives you the feeling that it's better, it's like natural, and they check your level and then they replace what you need. And that's actually not what it is. Bioidentical is a marketing term, right? Because like the standard estrogen and progesterone that we use, that is FDA approved, all of those are actually bioidentical hormones. So when they use the term bioidentical hormones when they're talking about pellets, it's actually probably not by all bioidentical. Sometimes they have the bioidentical, and then they'll throw in some of the horse urine estrogen and other combinations. And it's the combinations when you hear them say the word compounded bioidentical. The compounded bioidentical is not actually FDA approved. We don't have studies on that. They may be okay, but we don't know. Like, we don't have studies that, say in this number of women, this happens, right? So for those pellets, we don't know, and I don't really generally recommend them. But what they are is like a small pellet about the size of a grain of rice. And that pellet goes into the subcutaneous tissue, like in the fat cells, like in your butt area. And it stays there. They put a different combinations, estrogen, progesterone, testosterone sometimes. And that combination sits in your body for, I think, 3 to 6 months, depending on the dosages they give. And the problem with that is that sometimes that can, go wrong. If something goes wrong, and I've had patients where they came in, they had bleeding problems, we can't get that pellet out. Like, you'd have to go in and cut it out, like do a surgical procedure to try to find it, but you might not even be able to find it. And so you have to kind of wait it out. Like, if it's going to be 6 months, if there's something that's going wrong, and we just don't have the data on it to like support them. Does that answer the question? Yeah. Okay. So you mentioned that menopause starts a year after your last period. Does this include if you are on birth control? Not technically, because sometimes birth control itself can cause you to have, some bleeding. So we kind of, in general, people on birth control, what I tend to see with my patients that stay on birth control, and there's nothing wrong with staying on birth control, because you're getting estrogen. You probably won't have the hot flashes because you're getting estrogen higher than the hormone replacement therapy dosage. But a lot of times people will have a lighter and lighter period and it may disappear. And that might be your clue. I have just had a patient yesterday who was like, let me just come off. She had the NuvaRing for birth control, and she decided to come off of it. And she hasn't had a period yet, so we'll see. So that's that. Are there any symptoms, problems that seem to be more specific or experienced more by Black women? Now, Black women, we experience hot flashes a lot longer, like up to 10 years. And for, I believe, Asian women, it's like 4 years. For white women, it's like 6 years. So yeah, that's kind of same, right? It's a long ass time. Okay. Yeah, 10 years, Dr. Monica. So it's a long time. And in fact, I actually created a system called the Hot Flash Chill System with Black women in mind. Because the other thing with Black women, we have a higher incidence of breast cancer. We have a higher incidence of cardiovascular disease, heart attack and stroke, and we're dying from this stuff. And one of the things that we are not candidates for, if you have breast cancer and if you have heart disease, is hormone therapy, systemic hormone therapy. And the systemic hormone therapy is the type of hormone therapy that is needed to treat hot flashes. And so I created this system called the Hot Flash Chill System. Actually, let me close this out. And I had created it with Black women in mind, and it is hypnosis. It's basically educational information, a digital course on all of the treatment options for hot flashes, whether it's whether it is hormones, whether it's non-hormonal, pharmaceuticals, all of those things. It has all of that, all of the non-hormonal, all of the supplements, there's procedures, all of these things are outlined in that course. And in addition, it has the hot flash cooling audio. So there's hypnosis audios, and the mind is we're able to retrain the mind with clinical hypnosis. And remember that thermostat that I told you about, how the brain, it doesn't function properly once the estrogen levels are low. But we can use hypnosis to actually retrain the brain on hot flashes. And so here, I'm going to drop let's see, I'm going to drop the link in here for you guys. And I actually have a special for you all right now. If you want to, if you're having problems with hot flashes right now that you need a solution to, let's cut that. All right, here we go. I'm going to drop that in the chat there. It's hotflashchill.com. Oh, I think I sent that to Empress only. Let me just send that to everybody. Everyone. Okay, there we go. Yeah, and so to help us out to get through the transition. And it's actually really great for if you're trying to decide what you want to do and you have hot flashes and it's going to be a little while before you get to your doctor, you want something, or if you're on something already and you're having some breakthrough hot flashes, is a great option to like supplement and go along. Very calming, soothing hypnosis audios that actually are designed for Black women with our culture in mind. So you can pick that up. And then I also have a discount code for that is good through Sunday. Let me find that for you. That you can pick up. Okay, so go ahead and grab that. Let's see, what do we have here? Does the mental retraining also combat night sweats or sleep issues? Yes, yes, very much so. Like hypnosis actually is really great for sleep issues and those night sweats to keep you asleep and get you back to sleep. Let me see here. Do allergies seem to increase during perimenopause or menopause? Now, here's the thing. Because estrogen is a bit of an anti-inflammatory, we do see a lot of inflammatory issues flaring up. So I would not be surprised if that's something that you are dealing with, more allergies. Yeah. Okay, hold on. Let me get you guys this code.
We
Okay.
had an earlier question that asked, once in menopause, do moods mirror PMS?
They often do. And then it can be even more severe, they can be more severe because when you're in PMS, okay, this is the code. When you're in PMS, you have that next cycle coming up. So your hormones may crash down, but like once your period is over, it comes back up, right? So it can be really tough. And there is a hormone, it's called BDNF, that actually is important in our motivation. It's important in our drive and our connection to like pleasure and good things. And in menopause and perimenopause, that sucker, it just drops all the way down. Like it gets down. And so people can get really deeply depressed, and can lose motivation. The things that you used to love to do, or you're just like, meh, like I'm not feeling that. Like people who used to like to cook and like design the meals and set it up. And now they're just like, I have no interest in doing that. Okay, just pregnancy, perimenopause. I think we answered that one. Do women test false positive for pregnancy during perimenopause or during the first year leading to menopause? I don't believe that is any more than anyone else does. Okay. Do women who have hysterectomies also experience perimenopause or menopause? Absolutely. If you've had a hysterectomy, and this is where sometimes people get confused. A hysterectomy means that we're removing your uterus. It does not mean that we're taking your ovaries out. Now, some people have hysterectomies with the ovaries removed, okay? And that's called an oophorectomy. You take the ovaries out as well. But a hysterectomy, you're just taking out the uterus. So you will not have the bleeding symptoms because your uterus is no longer there to bleed. However, you can still have all of the other symptoms that come up. So any of the hot flashes, the vaginal dryness, all of the things that can happen. Are you accepting GYN patients as well as hypnotherapy? So I work at Altamed for the gynecology work that I do. So you can look me up there. And then I have a coaching and hypnosis program that I see patients. Oh, we'll see clients in. Yeah. Okay. What else? We good? Everyone's good? All right. I want you all to drop in the chat one thing that you learned here this evening. One thing that you didn't know that now you're like, oh. For 100 eggs thing, right? Yeah. You are not going crazy, Shannon. No, you're not. You were totally normal. Yes. And we should be talking about this. If you guys have little girls, even your sons, like everyone should know, your husbands, partners, we need to know. B, D, and F. Yeah, makes sense. Yep. 10 years, girl. Yes. It's not a game, but it doesn't have to be a painful 10 years, right? We have to find the solutions that work for us. And there's so many different options. Having a doctor that you can talk to about it. Some of the doctors, and give your doctors grace because we don't know. We didn't learn it, right? Like give them grace. There are a lot of telemedicine options popping up if your doctor is not like aware. Even if you have a doctor that is not aware but is willing to be open to the conversation, you're in a good place. But there are lots of other things popping up that are available to, complete your care. Thank you for practicing. Oh, it's a pleasure. Thank you for having me, guys. Yeah, Black women more susceptible to symptoms. Yep. Well, and then okay, I'm about to get on a whew, don't let me go off. But here's the thing. Like Black women, we deal with a different level of stress, y'all. Okay? We're dealing with microaggressions. We are dealing with administration, right? We are dealing with, most of us are, taking care of our families. You're the one that has the emotional labor. You're, coordinating the things, all of the things. All of this stuff has an impact. That's why we have the highest level of, our second highest level of breast cancer, and one of the higher levels of cardiovascular disease. It's stress, y'all. And so, we need to address not only the physical part of it, but like the emotional part of it is very important. The higher that your stress levels are, the worse your menopause is. There is a connection to it. So, yes, an excessive amount of stress. Yeah, bones like here's another like biology connection to it. Okay, so our adrenal glands are the other glands in our body that produces estrogen. But the adrenal glands are also the source of our stress hormones. So like if we're under stress, the adrenal glands are like, yo, we got to push out these stress hormones because the girl is stressed. Like we got to keep her on point. And so if your stress hormones are being pumped out by the adrenal glands don't have time to make an estrogen because they're trying to fight or flight and get you to run away from the, tiger. There's no tiger, but our stress is our tiger. So we've got to get that stress under control. We got to get rid of it. I mean, I'm like, if you got to leave your job, like, is the stress going to kill me or for my job, or is my heart attack? And I don't want to die from heart attack. Let's do what we got to do. Yeah, it does relate to high cortisol. Yep. Yep. Greater stress, worse menopause. Yep. So we've got to, and we'll be talking about some ways that we can do that. More trials, including Black women in studies. Yep. We need that. Okay. What else? All right. Well, I think that is it for me today. If you guys don't have any other questions right now, this was fun. Yeah. And then I believe there's a survey that's going to be going out. You're welcome. It's been my pleasure. A survey that's going to be going out to, get some more information from you. If you guys have things that you want to hear about in our next session, we can certainly talk about that.
Thank you, Dr. Williams, and thank you to all the ladies that are on this call tonight. I'm so glad we were able to provide a safe space. Loved all the questions, loved the discussion, and I'm looking forward to keeping this going next week. Just wanted to give a reminder that next week, Dr. Williams will talk about the common issues and solutions. And so I know that this is probably a further subtopic that we are all interested in and seeing how we can combat dealing with these symptoms. So looking forward to seeing you all next week, same time, same place.